time to start. There's a few people who will be trickling in, but we will go ahead and start. Hi, everybody. I am Kathy Reback, and I am the director of the Combination Prevention Core of the UCLA Center for HIV Identification, Prevention, and Treatment Services. I want to welcome you all to the third webinar on the topic, why is it so hard to get people housed? I'm very excited about today's webinar because in addition to addressing unhoused individuals and issues in Los Angeles, today we're expanding our scope and we have panelists who are joining us from Houston, New York City, and Seattle. I am also very honored to introduce our two facilitators for today, Dr. Narita Milburn and Eddie Sanders, and Narita and Eddie will then introduce the panelists, but I will first introduce them. Eddie Sanders is the co-chair of the CHIPTS Community Advisory Board and director of grants at Northeast Valley Health Cooperative, and he brings over 20 years of experience in addressing healthcare needs of vulnerable populations with a significant focus on working with the unhoused. His leadership in the cooperative healthcare, I tried to get away from these, but I think I need them. His leadership in the Cooperative Healthcare for Homeless Network underscores his commitment to collaborative initiatives aimed at ending homelessness in the region. Dr. Milburn is the CHIPS Development Core Director and a professor in residence at UCLA. She specializes in community psychology with a focus on homelessness. Her extensive research focuses on homelessness, substance use, mental health, and family-based interventions, with notable contributions to understanding pathways into and out of homelessness and designing behavioral interventions for unhoused youth and their families. She continues to lead impactful studies, contributing to efforts reducing substance use disorders and HIV transmission, and mentors a diverse researchers in the field of health disparities. Before I turn this over to our facilitators, I do want to remind everybody that at the end of the webinar, right before we close, we will have a raffle with $25 gift cards. I think we have 3 raffles. Dami will definitely correct me if I'm wrong on that. So now I will turn the webinar over to Eddie and Dr. Milburn.
Thank you so much, Dr. Reback, and good morning, everybody. I'm happy to be here, and it's an honor to be co-moderating this important panel, this important webinar, and it's an honor to be co-facilitating today's presentation with Dr. Milburn. Before we get started with this morning's presentation, Dr. Milburn and I are going to be spending just a few minutes kind of introducing our esteemed panelists and giving you a brief overview of the work that they're doing and that they've been doing in their respective communities. First, we have Aileen Reynolds, who is the Assistant Commissioner of Housing Opportunity for the New York City Department of Housing Preservation and Development. Also joining us today is Anita Wells, Senior Director for the Insight Safe, which is an initiative that comes out of LA Mayor's office.
Our third panelist is Lisa Doggart, who is the co-executive director of policy at the Defender Association. And she spearheaded a racial disparity project since 1998. And she's really been instrumental in leading successful litigation, challenging selective drug arrests of Black individuals in Seattle. And then our fourth panelist, and by no means last, just fourth in order, is Dr. Hamilton, who is an associate professor of psychiatry at the Montgomery Medical School at the University of Texas, Houston, and she co-directs the Center for Behavioral Health Equity and Outcomes Research. So welcome to all of our panelists, and I'm going to turn this back over to Mr. Eddie Sanders.
Thank you, Dr. Milburn. Again, thank you to all of our panelists. We're going to go ahead in the order of the introductions and allow our panelists to give a report out of the work that they're doing and the initiatives that they're sort of spearheading as it pertains to addressing homelessness in their respective regions. So, Aileen, the floor is yours.
Thank you so much. And thanks so much, everyone, for having me here today. I have a few slides I'm going to use to aid in my presentation. I hope you can all see that. So thank you so much for having me. Again, my name is Aileen Reynolds. I'm the Assistant Commissioner of Housing Opportunity for the New York City Department of Housing Preservation and Development, which we acronymize as HPD. And my role at HPD is really to connect New Yorkers to housing through the various affordable housing programs that we have here in New York City. So the need to house homeless New Yorkers is greater than ever. And I think, we're feeling this nationally, and we're definitely feeling it in New York City. Something unique about New York City, for those who don't know, we have a right to shelter law here in New York City, and it extends to New York State, that New York City has a legal obligation to provide shelter to any adult and family that needs it on any given night. So every night or every day, new individuals and families come to our intake centers and say they don't have somewhere to stay that night. And we as a city are obligated to provide shelter for those households. There are approximately 89,000 individuals in our shelters every night. That is a huge number of folks, and that's based on current census data. And this doesn't even include our street homeless population, which is, not nearly as large, but is still present. It doesn't include people who are couch surfing or doubled up or in other temporary housing scenarios. And it doesn't include our newly arrived asylum seeking neighbors who are sheltering at emergency respite centers that we're standing up separate from our New York City shelter system. So it's a huge amount of individuals, and about a third of them are children. So a lot of children and, children in our school system are homeless themselves and with their families. And our most common household composition for a household experiencing homelessness in our shelter system is a single mother with one or more children. So the need is great. And because of our right to shelter law, New York City has kind of a unique perspective and situation where, we are obligated to provide this shelter. It's extremely expensive and a huge line item in the New York City budget to provide this shelter for these households. But it also provides us a unique opportunity to centralize our housing options and coordinate the exit of these households from shelter to permanent housing, because we have folks already in our system. Our shelters are staffed with housing specialists and case managers who have contact with all of these folks, and it allows us, the ability to kind of centralize our efforts and help folks find permanent housing. So in my world at HPD, we create affordable housing by partnering with private landlords and developers and providing them various incentives like tax abatements or tax credits or subsidies. And in exchange for that, they have to make their housing affordable. And oftentimes they have to make housing specifically for people exiting the shelter system. We actually have a local law that requires 15% of all new construction developments that are financed by the city be set aside specifically for folks who are exiting the shelter system. So those units are not made available to the public. They're only made available to people who are experiencing homelessness, as well as our robust supportive housing programs that come with, congregate on-site services for people with special needs. And all of our affordable housing that is offered to the public is offered through a housing lottery system. Because the demand is so high, we have a really robust lottery system on New York City Housing Connect, where anyone in New York can apply for their chance to access this critical resource. But since we're focusing today on people experiencing homelessness, I'll focus in on the two types of units that is most common for our households to access. So supportive housing, I'm sure many of you are familiar, is known for having on-site supportive services that serve a certain population. So our shelters will provide clinical assessments by licensed professionals on people in shelter to determine if they need supportive services or if they meet our population definitions. And if they do, they will be connected with supportive housing for their permanent housing option. And we serve a variety of populations, from single adults with substance use disorder to youth aging out of foster care, people living with HIV, people with serious mental illness. There's several categories that we will serve, and make sure that when people enter permanent housing, they have the on-site support they need to stabilize and have a successful tenancy there. Separate from that, we have non-supportive homeless housing, which is just our affordable housing, as I mentioned, that is set aside for people in shelter. So households just need to be homeless to qualify. We try and match them to the units that they may be most interested in based on where the unit's located or what their household needs are. But in general, there's no qualification in terms of determining housing readiness or anything like that. It's just simply in our shelter system and needing permanent housing. We do prioritize people who are long-term stayers in our shelter system or are chronically homeless, as some of our federal programs require. And of course, we want to help those individuals exit shelter. And a lot of our programs are layered with other affordable housing programs or rental subsidies that have additional requirements for eligibility, such as income requirements. But most of our vulnerable populations are extremely low income, and so they typically do qualify for these programs. Lastly, I just want to highlight some of the things that New York is specifically working on and financing for these types of initiatives. One is our City FEPS program, which is a tenant-based voucher program similar to Section 8, except that it's completely administered by the city and it's mostly funded by the city. And it is a tenant-based voucher for people in order to find and keep housing by paying the majority of the rent to the landlord, and the tenant is only responsible for a small share. Essentially, almost all of our folks who are in the shelter system qualify for a City FEPS voucher, and this is how the majority of our residents of shelter are able to exit into permanent housing, is with the assistance of this voucher program. Separately, but similarly, we have a New York City 1515 program, which is a New York City funded supportive housing program where we provide rental assistance and service contracts for people who are homeless and need supportive housing. It's just another tool in our toolkit that the city was able to create to expand our supportive housing options outside of what you may be familiar with as federally available, like the continuum of care, other things. And because it's city administered and financed, we're able to make it responsive to what the city needs, and is a great tool that we are utilizing heavily right now. And lastly, I really just want to highlight how critical it is to have strong partnerships in this process. Housing homeless New Yorkers is a collaborative and interagency process and has a lot of players in the game to make it happen. And it really is these strong partnerships that we're able to make, both internal and external to government, that makes it possible for us to house the folks we can house through the three programs I mentioned: the housing lottery, homeless set-asides, and supportive housing. My unit was able to house 15,000 households last calendar year alone, through these programs. And it is how most folks are able to access stable housing in New York City. So it's really critical that we have engagement from all of our colleagues and our partners, and we couldn't do without them, for sure. So thank you so much for having me. I'm looking forward to the discussion, and I'll pass it back to you, Eddie. You're muted, Eddie.
Oh, sorry about that. Thank you, Aileen. The next presenter that we have scheduled to present is Anita Wells from the LA Mayor's Office. Anita, the floor is yours.
Good morning, and thank you, Eddie, and thank you everyone for being here. I am excited to speak on behalf of the Los Angeles mayor's office and be able to talk about the great work that she is doing to lead on the issue of homelessness across the city of Los Angeles. So I'm going to give you a brief overview of the approach that we've taken, who I am, what I do in leading this program, and then what our accomplishments have been to date. Back on December 12th, Mayor Bass and the Office of Housing and Homelessness Solutions launched a program called Inside Safe to immediately bring Angelenos indoors. She saw the urgency of unsheltered homelessness, which was very vast in the city of Los Angeles as well as the county, with numbers for the city being upwards to 46,000 unsheltered homelessness, but in the county itself, it was over 75,000. We wanted to be able to prevent people from returning to encampments. And so she created this bold sort of citywide approach that was very much steeped in housing and led in housing and services, which is a lot different than any other approach has been implemented in Los Angeles. Prior to the mayor taking office, the previous administration did leave a sort of it up to the council offices to take on their approach to homelessness. So there wasn't a unified or citywide approach. It was sort of left up to each council office to figure out how they would want to deal with this issue. Then we experienced COVID, and so our numbers were even further exacerbated by that. What the mayor came in and did and said is we're going to take on one approach that allows us to clear our streets and ensure that we get folks who desire to come inside, connected to services, and get them along in their housing journey. In order to do this, there was a couple things that she had to do. And the first being to create an executive order that allowed for us to be able to implement Inside Safe. So we call ourselves ED2, Executive Order 2. And so this approach was very community-centered, very proactive, housing-led, and it offers people experiencing homelessness an opportunity to voluntarily move indoors with social health and behavioral health services to begin their housing journey and secure stability, permanence, and sort of reestablish life in the way that they once knew it. The program has been around now for about a year, and with the efforts of multiple partners, we have brought in over 2,087 individuals indoors as encampment communities. And we did it across all 15 of our council districts in Los Angeles. Given its community-focused approach, we've been able to have a great retention rate. We're sit at right around 79% in comparison to other programs that average around 64% while working towards permanent housing. Some of the goals of Inside Safe are definitely steeped in partnership with the Los Angeles County Homeless Service Authority, so LAHSA, nonprofit community-based organization, service providers, the county itself, and then other persons that work in the field of homelessness. We do have 5 tenets to our program. Number 1 is to reduce loss of life on the streets by building trust and maintaining relationships with people and communities residing in encampments. We offer a safe and voluntary option for shelter that ensures a viable pathway to permanent housing stability, streamline a comprehensive social health and behavioral health services to participants, eliminate street encampments altogether, enhance safety and hygiene of our neighborhoods for all residents, businesses, and neighbors, and then supports communities, council districts, offices, and businesses impacted by the safety and public health consequences of encampments. And the reason why this was done and had those 5 tenets is we wanted to be able to have everyone have skin in the game. When our mayor was first elected, she said, there are many entities that are working on this issue. However, we were all sort of working in silos. Her approach has been to lock arms with all of the entities and highlight the things that each entity is really good at, streamlining all of our efforts to be able to put an end to street homelessness. In the first year, we were able to, as I said, bring in over 2,000 people, but we're really looking at scaling up our efforts and ensuring that we can double that number most definitely this year, and then through some of our other strategies on homelessness that we would ensure to do more. We have been able to conduct over 36 operations. As I told you, we've done them in every single council district, showing that if we do this effort, how we would be able to bring people indoors and be able to get the help that they need. As I told you about our success rate, we've been able to have a strong retention, and we're continuing to grow that number. We're going to make sure that we're able to do that across our city. I am flipping now over to impart my notes. 1 second. Okay. And so I just wanted to share some of the other things that, some of the other priorities that we have in order to continue to move on the work that we've been able to do. Pulling up the right slide here, 1 second. Google Drive is not being my friend this morning. All right. Seeing that it's not pulling up, like I said, Inside Safe is just one of the many efforts that the mayor has put forth in order to end street homelessness. We've been very successful in our efforts in the first year. We're going to continue to grow and expand on those efforts. It's a multi-pronged layer. We do have several other things that we're working with our housing authority, and they are helping to bring our expedite units to bring them online, so that as we bring people in from the street homelessness in the tents, that we're able to get them along their housing journey, do that continuum of care, and ensure that we're able to place them into the program. Being that my communication is failing me right now, I'm going to go ahead and pass it back to our moderator, and then I will be on standby for questions and be able to share more of that in the other portion of our Zoom meeting here. So thank you very much, and I appreciate the opportunity to be able to speak with you all.
Great. Thank you so much, Anita. That was really a wonderful presentation. Next up, we have Lisa Daugard from another representative from, I believe, New York. Lisa, the floor.
Well, I'm actually I'm actually in Seattle, but I was long ago the legal director of the Coalition for the Homeless in New York. So cover that in distant memory. I will give just a little background on why I'm here. That the opening intro said that I was a litigator, which is true, but that also is a bit in the rearview mirror. I was a public defender for many years, and that will come into play in describing the sort of population of focus that we work with. But starting about 13 years ago, my own professional journey took a turn when we, after litigating for many years challenges to racial discrimination in Seattle drug arrests, which were for a very long time overly concentrated on particularly Black individuals. We, in resolving that litigation, launched the LEAD program, which has been replicated in many jurisdictions around the country. There is a really strong LEAD program in Los Angeles, for example. And that is this is just background, but a street-based case management program to which law enforcement and community members can refer people who commit law violations related to behavioral health conditions or extreme poverty. But everyone can see that community-based care is a better strategy than enforcement and incarceration. So we began working with many partners on that model back in 2011. And that is the origin of the work that I'm going to talk about here, which is Just Care. Starting in 2019, pre-COVID, we had already recognized that LEAD and street-based case management is better than sending people to jail and into the court system, expecting that that's going to generate progress toward recovery. But that might be the wrong point of comparison. You know, we, with just flexible funds and intensive case management, we're definitely doing better than people were in the old system as usual, going through the criminal legal system. But if you looked at that question another way, were the people that we were working with doing well? The answer was no, because we did not have, in general, access to housing resources or even sheltering resources that were appropriate to this population. Our folks did not, the people that we work with, in general, did not end up in the shelter, in a congregate shelter system, either because they didn't feel comfortable there, or more often they would try and they would get excluded from that system because of behaviors, because they violated rules, including drug use or other behaviors, or because their mental health condition was not compatible with a congregate living environment. So our folks tended to be both chronically homeless and outside of the shelter system. And without, you know, we know from all the research supporting Housing First that while housing alone doesn't, you know, guarantee recovery in the absence of housing is exceptionally difficult. And so people are just not making as much progress as we knew might be possible with access to housing then, but we didn't know where. So in the LEAD model, in 2019, we resolved that we thought the model itself should evolve to include access to housing as an essential element. How would we do that? Didn't have a plan for that. Then in 2020, with the advent of COVID, with congregate shelter de-intensification, the shuttering of jail booking, and to a great extent the court system, and just economic destabilization of the most marginalized people, we saw, as did, you know, all communities on the West Coast and most communities in the country, a growth in very visible unsheltered homelessness. In addition, a lot of really difficult behaviors associated with those encampments because people were living in the illicit economy. These are people who didn't receive any COVID relief funds because they didn't have a job and they didn't have a 1099. And so they were, and the formal economy with which people had some association really shut down. So people were making their living selling sex, selling drugs, selling stolen property. And it was happening in encampments, and it created, you know, a felt and real public order crisis, and thus allowed a response to that problem to be a good candidate for COVID relief funds. So King County allocated a consortium of programs in organizations, including ours, and we were the project manager, funds to, you know, do a version of what many communities did, lease unused hotels to provide non-congregate shelter. But and then in our case, we knew that we wanted to focus on a population that was engaged in illicit activity, overwhelmingly experiencing substance use disorder, and had bad experiences being rejected by the shelter system. So we created various intensive case management teams that were able to address and support people who had been living in those circumstances, and to do so in a way that was not itself chaotic, in which people who were and continued to use drugs would be safe and supported in connecting to behavioral health services and not die of overdose. I will just pause and say we've lost, I know there's been some national conversation about overdose risk in non-congregate facilities and permanent supportive housing, which has accelerated during the fentanyl crisis. In our model, we have not lost a single person to overdose death in 4 years, having worked with over 1,000 people. So there's something protective about the approach taken, which happy to talk with folks about if you're interested in exploring what we attribute that to. So Just Care was a multi-organizational alliance. When COVID funding ended, sustaining that has been difficult, and really, it's only our team housed at my organization, which is now Purpose Dignity Action, no longer the Public Defender Association, because we're no longer public defenders. We have an in-house team called Co-Lead, and that really is where the Just Care methodology continues to live and be applied. Today, just to give you kind of a current state, we are working to resolve encampments on state transportation rights of way. I think nationally there is a sort of, increasing attention to large communities of folks living unsheltered on state, under overpasses and on state rights of way. State of Washington has dedicated project focused there. And so we are using the Just Care methodology, which I'll get to in a second, to resolve encampments located in those areas in King County. And then the other half of our program is focused on individuals who are exposed to the criminal legal system because they are both engaged in illicit activity and living outdoors. And so those individuals, as a public safety strategy, are able to come into our program, receive intensive case management, and then housing navigation to land in a permanent housing resource, which is happening to a greater and greater degree as we gain sort of preferred access to, I'm putting a link to some research on that, preferred access to our coordinated entry system. And this is where I'll really pause and say, it's not just that we, focusing on this population, have been able to bring people in because the shelter lodging, we call it lodging because it's more than most shelters are, when people think of that word. It's not just that it is appealing, dignified, attractive, and private. It's also that people know that they will be received as they are and welcome as they are, and that their full condition is understood. Our team involves many people with lived experience of the criminal legal system. And there's a sense of recognition, also a sense that we have a plan for drug use. So we've seen acceptance rates of over 92% when we offer this resource. People do say yes. And so I think we've gone a long way toward exploding the myth of service resistant populations. It's just we had people resistant services. And so offering this different array, and I know many communities have experienced this, we get very different responses and answers. But then this is not meant to be the final destination. It's not permanent housing. We have fought sort of a system change battle and achieved a limited, I don't know how long we'll sustain this, but a limited preferred access to our coordinated entry system, so that the individuals we're working with who are understood to have not only, strong individual need and are chronically homeless, but also had a major impact on community safety and order. So this is why this priority has been created. We are able to sort through the available permanent housing options and make strong and good matches to people's individual circumstances, so that once we make that match and clear obstacles, which we're able to do rapidly, and people move in, they are in a good match and remain. So we're not losing people out the back end because of their very high barriers and challenging behaviors. And then we have also found that even with all of that good matching, many of the people we're working with exceed the level of care that is offered in most permanent supportive housing projects. And to compensate for that, we have created an aftercare program that is protective against eviction and loss of those housing placements because of conditions or behavior. And that has proven very stabilizing. So we're essentially equipping PSH providers to succeed with our population when otherwise it was not looking good in terms of retention. And I'll just close by saying, we know that there is an intersection between homelessness and the criminal legal system. It's not just that, homelessness generates exposure to the criminal legal system, but also the legal system itself interrupts people's recovery journey in a way that almost guarantees return to the street. And so in our approach, we're not only coordinating healthcare and sort of wrapping around with social services, we're coordinating criminal legal system involvement. And so in communities that have a lead framework, really recommend tying these two things together, so that you have lead criminal legal system coordination, ensuring that warrants are quashed, cases are resolved, and often not filed because there is an alternative strategy for reducing criminal involvement, so that we're not seeing that system sort of interrupt all the good work being done in the housing system and in the outreach and case management system, and the left hand and the right hand kind of, undermining one another. I'll close with that and really appreciate the chance to be with you today.
Great, thank you so much, Lisa. And last, but definitely not least, we have Dr. Hamilton, who is going to be speaking, Dr. Jane Hamilton, who's going to be speaking on her work in Texas. Take it away, Dr. Hamilton.
Thank you. So hopefully I'm sharing my screen now. So it's an honor to be here. Thank you so much. And I'm going to briefly talk about some of the programs that we're running out of the Department of Psychiatry here at the University of Texas Health Science Center, Houston, and then provide an overview of some of the successes that Houston's having, which has really contributed to our success. So since 2018, I've been the project director and principal investigator for the UT Health Homeless Outpatient Mental Health Expansion Services Program. We call it UT Health Homes. And it started with a 5-year, $2.5 million SAMHSA grant that was awarded in 2018. And we were just re-awarded a new grant from SAMHSA for another 5 years. So we've been fortunate to have 10 straight years of funding. And it's a community academic partnership that we deliver integrated behavioral health treatment and recovery support services. So really the focus that we really strive to have is the delivery of what we call high fidelity evidence-based interventions. Years ago, when I first started in the Department of Psychiatry, I was providing some clinical supervision at our psychiatric hospital. That our department runs the largest academic psychiatric safety net hospital in the country. And about 3,000 patients a year are experiencing homelessness. So I was over there teaching, and we watched a video by SAMHSA on how cognitive behavioral therapy was being implemented by the University of Pennsylvania to really target in on some of the maladaptive thinking that people that are experiencing chronic homelessness have developed, really having a lot to do with distrust and community exclusion that really served as a barrier from them engaging in services. And I saw that, and I thought, what if we could do this in Houston? And so about that time, a call came out from SAMHSA to apply for what their mechanism for integrated behavioral health treatment through SAMHSA. It's called Treatment for Individuals Experiencing Homelessness. So we actually applied to deliver this intervention in Houston, and we have community partners. Dr. David Buck, who I noticed is on I'm very honored that he's on the webinar today, and he started healthcare for the homeless FQHC in Houston. So I was able to get a lot of mentoring and collaborations going. So we started this project, and so we work with multiple community-based partners, but really at the core of what we do is we have a strong, dedicated team of highly trained providers that include clinical social workers that they receive their clinical supervision to become independent therapists as part of our program. We have medical students, psychiatry residents, several are on the webinar today. We have master's and doctoral level public health students. So many of the trainees and providers are within the University of Texas Health Science Center at Houston. And so what we do is we each provider group is training to deliver behavioral health interventions that are adapted for people experiencing homelessness. We also work with community health workers. And at one point we had there's a Houston Methodist hospital system that's a part of the Texas Medical Center to which we belong. And so we were able to get a community benefits grant from them. And we developed a nutrition focused community health worker intervention to really combat food insecurity among people transitioning from chronic homelessness into permanent supportive housing, because that's actually a major problem that we read about. That was actually a study done in Los Angeles that about 65% of residents in permanent supportive housing experience food insecurity. So we started that program as well. So we are a trainee program, and to date we have served approximately 530 people experiencing homelessness, and they must meet criteria for a serious mental illness or a co-occurring disorder. So we, when we consent people for participation, we use what's called the mini psychiatric assessment. We also use a lot of validated clinical assessments to not only make sure that the person has a serious mental illness, we want to know which one. We also want to identify any physical health problems. So we administer what's called the SF-36, but we definitely are collecting a lot of clinical data, and we are tailoring treatment to make sure that we do the best job we can to meet the needs of people experiencing homelessness. So when we started in 2018, many of the people that we enrolled were unsheltered and living in encampments and coming to a day program where we were co-located. We would also go out into the communities, to the encampments, to recruit people directly. But as Houston has made a lot of progress in housing people that are unsheltered, we have started to more co-locate in what are called respite programs, that are hospital step-down programs for people experiencing homelessness and shelters and other, and in some permanent supportive housing programs. So our outcomes that we've achieved to date include reduced mental health symptoms, improved perceptions of mental health recovery. So we are a recovery-oriented program, and we administer what's called the mental health recovery measure. So we are wanting patient-reported information on our patients' perspective on their own mental health recovery journey. So we tailor what we do to foster recovery. We have found that our interventions are reducing substance use. We're really focusing on relapse prevention right now. We also are focused on improving physical health status, receipt of needed benefits and social services, as well as improved housing stability, because our primary outcome is how, linkage to permanent housing. Just a couple of quick notes on what's been mentioned so far. So we do have had a partnership with a legal aid clinic for people experiencing homelessness. We link all persons enrolled in our program get linked to primary care, as well as psychiatric medication management. And we work with a program called, I don't know if y'all have heard of SOAR, but it's a SAMHSA program for improving the rates of SSI and SSDI applications. So we work closely with our SOAR workers and legal aid clinic in Houston. And we also screen for SNAP benefits, IDs. So we definitely are partnering with other organizations that provide case management or providing it ourselves. And our research assistant actually just became trained. She's on the webinar today too, to become a housing assessor. So we work very closely with our HUD continuum of care, and they allow us to actually provide housing, these coordinated access housing assessments as well to help. So that's what we do. So just another area that we've been involved with our program is policy. So when we received our first SAMHSA grant in 2018, the state of Texas contacted us, and they asked if we would be willing to facilitate policy summits around Texas to improve housing options for medically vulnerable populations in particular. So we created a community academic partnership, And we convened 3 regional housing policy summits across Texas in collaboration with regional stakeholders. We were supposed to actually convene 11, but unfortunately we could only convene 3 because of COVID. But what we were able to do is develop an implementation toolkit. So we first conducted policy research to understand some of the constraints that and some of the issues across the US. And so we came up with scripting, with interview guides. We recruited for panels. We recruited keynote speakers. We convened strategic planning sessions, focus groups, and we disseminated these best practices out across the 3 regions. We had one in Houston, we had one in Central Texas, Temple, Texas, and one in San Antonio. And the goal of these the overarching goals of these policy summits are really just to be there to assist the local communities in expanding housing availability and accessibility in ways that work for them, to really enhance tenancy support services, and to really identify innovative regional solutions to address the existing gaps and barriers to housing for medically vulnerable populations, in particular, those that are at risk for housing instability because of their medical conditions. And it was a wonderful experience. There was a lot of engagement and a lot of creative solutions. One of the ways that we're addressing homelessness, not only building more permanent supportive housing, but the tiny homes movement has really taken off across Central Texas. So we had a lot of people. All areas are different. I do believe that in Houston and even across Texas, there's a can-do mentality. So there were a lot of people, businesses, nonprofits coming forward, offering to build housing and start housing communities. So we believe that this has been successful. Also in the Houston region, it's been particularly successful in drawing attention to this issue and really engaging our local mental health authority, our continuum of care, our hospital systems, and kind of looking at the housing issue, looking at issues like high utilizers, looking at issues such as the need for respite. So the last program that I've been involved with over the last few years is working with our local mental health authority, the Harris Center. They started a psychiatric respite program. And so what respite programs do, if you're not familiar with them, is these are transitional step down programs. Mostly they're used for people with medical conditions following an acute care hospitalization. But we developed what's called a psychiatric respite. So these are for patients getting discharged from a psychiatric hospital. They're experiencing homelessness, but they're not stable enough to go into a shelter, so they can go into this respite program. It's highly valued by mental health consumers and providers in our area. It's a 90 to 180 a day residential program. It provides mental health treatment, care coordination to address social determinants, as well as linkage to permanent housing. And then our team, through our SAMHSA grant, delivers the cognitive behavioral therapy there. What we have found to date is that 25% of these really often very difficult to house individuals have been linked with permanent housing through the HUD Coordinated Access Program. And again, just to mention again that many of these residents are discharged from the psychiatric hospital that my department runs, which is treating approximately 3,000 patients a year experiencing homelessness. And a lot of times these patients are not within the same HUD coordinated access system. So we're trying to bring these systems closer together to improve access to housing for people with serious mental illness. So a few key policy items and housing practices that maybe aren't unique to Houston, but we have definitely had a lot of successes here. So we are a housing first city. That's a major focus of our homeless response system. Since 2021, we've decommissioned 115 encampments. There's been a 62% overall reduction in homelessness since 2011. And during COVID, there was a $165 million investment. This is a city, county, and HUD COC collaboration. And just in these 2 years, a little over 9,700 individuals were housed. And so one of the things that makes Houston really great is we are a highly collaborative city. So we have 100+ organizations that are led by our HUD COC. It's the Coalition for Homeless Houston administers the, it's called the Way Home. That's our continuum of care. So these agencies work together to reduce homelessness, and many of these are they're public, private, and university partnerships. So we have 3 medical schools in Houston. We have many of the healthcare providers are actually coming from our medical schools, and they are co-located in these federally qualified health centers and nonprofit systems. So here's a this kind of shows the decline in homelessness with this chart here. You can see that we've had some successes. We still have a long way to go. As y'all can see that we have that we've decommissioned 115 encampments. Many of the people that have been unsheltered on the streets have gone into permanent supportive housing or rapid rehousing, and many have been engaged. So as you can see here in this pie chart, we only have 13% that we've documented as refusing housing. And just to kind of show our model, so we have 3 components of our housing strategy with permanent supportive housing. So it's supposed to go towards the highest acuity patient population with rapid rehousing more in the middle, and then we are providing a lot of homeless diversion. So, and then here are the numbers. You know, one of the areas that I'm working in is to try to advocate to get more of our seriously mentally ill patients into permanent supportive housing versus rapid rehousing, and using some of our clinical assessment data to advocate and to really coordinate with housing case managers. It's a process, you know, and so this, again, thank you for having me. It's an honor, and it's Houston, so thank you.
Thank you so much, Dr. Hamilton. That was a really great presentation. Dr. Milburn, do you want to sort of field 1 or 2 questions that are in the chat?
Well, I'm going to, just for the sake of time, so that we can really leave time to really discuss how all of these excellent programs relate to people with lived experience of homelessness and who are experiencing HIV, which is really important for us today. I'm just going to ask really one of the questions in the chat, and I'm going to suggest that the other questions be addressed by people reaching out to the presenters later, I think via email. And I'm just going to really probably take the first question, which has to do with the screening that's used in New York City for people to screen for people whether they need supportive housing or not. So the question was, what % of people, and this is for really for you, Aileen, what % of people screen into supportive housing? And then the second piece of this, and it kind of ties somewhat to HIV, it does, is can people who are medically fragile get same-day housing? So 2 quick questions for you.
Sure. Yeah, so that's a great question. I don't have stats on our populations handy. I will say that it is not the majority. The majority of our homeless population are able to live independently and do not need supportive services. If anything, we find that they need more stabilization services, such as just transitioning out of that temporary shelter life and into permanent housing with some basic life skill support and some general therapies that we all need ourselves. I will say that in questions of the same day housing, no, we don't currently have the ability to do that. And that's something we're striving towards as a city. We really recognize that every day in shelter is another day for potential trauma to happen. It is really, it's not a pleasant place for most folks to be. And it, of course, is destabilizing. And so we are really focused on reducing the amount of time that someone is in shelter in order to access housing. We do have some pilot initiatives in the city, such as a street to home program, where we're trying to get folks off the street and into permanent housing without having to enter the shelter system. It's been a focus of ours to avoid needing to have someone else enter the shelter system at all. But again, that, we're piloting those programs, but it doesn't take away the fact that we have 89,000 people in shelter that need housing immediately. One of the challenges that we have, just quickly, and kind of relates to your question about who needs the supportive housing, is that a lot of supportive housing programs have like pretty prescriptive service definitions and who they serve. And it can really force people to be put in a box. And sometimes we can't even find folks who fit in that box because it is so prescriptive, and it becomes a barrier to filling units because the service provider or the contract or the federal funding that comes with is really like making it really restrictive about who can live there. And so in New York, we're trying to move away from population definitions and trying to do really general SMI, SUD, chronic homelessness. We're trying to move away from chronic homelessness, just any homelessness experience. Really trying to move away from as many categories as possible so that folks can just more easily qualify. And again, remove barriers that it takes every day for someone to get out of shelter and into housing. So that's been our focus. We're trying to move in that direction. There are some federal programs that this national level has the rulemaking on that one, and we try and advocate as much as possible.
So thank you, Aileen. I saw a lot of nods from the other presenters as well. And there were questions for the other presenters, and maybe in our next series of questions, we can fold some of the answers to those questions into the discussion. But I'm going to turn it over to Mr. Eddie Sanders to really kind of take all of what we've heard today and put the lens of HIV on people with lived experience of homelessness. So, Eddie.
Thank you, Dr. Milburn. And yeah, I'm listening to all of the presentations today, and I find it really striking that what we see happening in LA in some way, shape, or form is being sort of scaled up in different ways, but in similar ways at the same time as it pertains to housing prioritization, coordinated entry, and even hospital partnerships, looking at clinical data to really sort of help stabilize that sort of really vulnerable patient who is precariously housed or homeless, experiencing homelessness. So with all that, with everything that's been going on, what policies or legislations that are existing in your communities today that you can speak of that have a specific focus on ending homelessness or addressing the needs, the housing needs for individuals living with HIV and AIDS?
We are not that, but the creation of an environment in which people feel comfortable allowing the investigation of their health history, development of a health history, connection to a health home, a primary care physician, establishing insurance. This is fundamental to HIV, to supporting individuals who are homeless or have been homeless with HIV. So I think there are just, sort of good health oriented practices that are without which, people are at extreme jeopardy. Continuity of care, stable location. It's night and day trying to begin a recovery journey, a discussion about safer, practices, self-care, utilization of a medical establishment that, daily kicks our people out, is is the best way to address, you know, a multitude of potentially serious health issues. I mean, one of the most horrifying findings for us over the last 4 years has been, and I mean, I know like we've all read research saying this happens, but watching our participants and staff be escorted out, treated poorly, not welcome at, you know, the sort of standard health system is, you know, we have to accompany, we advocate, we put a protective wrap around the person to make sure that they actually get care. And that is sad. I mean, that shouldn't be like that. But while it is like that, we have to, yeah, we have to really sort of, from initiation of the investigation and people being interested in life-saving care, life protective care, having hope for a meaningful life that makes your interest in extending your life, you know, a real project that somebody's interested in tackling. For people using fentanyl, that's not top of mind, right, for a lot of people. So making life, this is what the SAMHSA recovery definition is all about, is it makes sure that life has meaning and hope, and that is realistic for people to think about surviving to have a meaningful life. And then you can tackle some of these health objectives. But then once people are ready to do that, making sure that that very resistant system is penetrable by our patients / participants is the work of intensive case managers.
Thank you, Lisa. Ace, I see that you have your hand up. Do you have a question or comment?
Thank you. Just real fast. Thank you all for being here. Also, as we all know, it's the first week of Black History Month, and it's National Black HIV/AIDS Awareness Day. So Lisa, you spoke a little bit to this, but I would love to get everyone's perspective, or just maybe a couple of your perspective. When you're looking at the amount of discrimination that Black people experience in your respective cities, which of course leads to higher rates of criminal justice involvement, housing discrimination, so on and so forth, turning it around, because this is not about the patients and the clients, this is about the society they live in. So when you're looking at decriminalizing sex work, decriminalizing HIV, condoms as evidence, stop and frisk, loitering, all the things that are about how Black people are abused in your respective cities. Is there anything we can do to fix what we're doing as providers to provide a more equitable experience for individuals who are going to experience racism often in those HIV providing services, whether it's HOPWA, HUD, or whatnot? Because this is, I can go through the data stats of each one of your cities. It's abhorrent. So like, what can we do to support Black people on a day like this?
So if it's okay, I could answer. So I just wanted to just speak to your question and just talk about a couple of things we're trying to do. I hope this answers it, but we have very significant racial disparities in homelessness in Houston that are just persistent, and that we're also really concerned about the way providers are interacting with our homeless population. So one of the things as part of our new SAMHSA grant that we're doing is we're going to train 415 providers across Houston on what's called the National Standards for Cultural and Linguistically Competent Services, class standards. And we're finding that a lot of our providers haven't heard of them yet. So it's a small thing that we're doing to try to educate people and bring more attention to this important issue. And completely agree with the need for legal and system change. But I think bringing awareness, because I think, what we at least see in Houston for our homeless service providers, as many of them are like faith-based communities, people that are getting into it because they want to help, but they don't really have a lot of training. And then they really sometimes who they've even interacted with, it's very limited, or they're getting into things because of their own experience. So when someone has an experience slightly different from their own, it's very hard to sometimes train people around seeing people more holistically. So that's one of the things that we're hoping to do over the next years, to provide these training courses, if that makes sense. So.
Thank you.
Yeah, I can also just second some of what Lisa's saying in the chat. We we have to fight with providers and owners on their criminal screening history standards. And it's really something that is disheartening when we have to have the conversation at all. In New York City, we don't allow for any criminal screening to be done on any supportive housing referral. We don't allow any screening at all for affordable housing. We have very limited screening, very limited look back period, and a finite list of convictions that could be considered. But even that is something we took a long time to get to, and we're still not done. But I will say, you know, I recognize that being a provider is very difficult, and a lot of your funding or support is outcomes based. And so I think that sometimes that drives fear of blank impacting your organization's performance. And I just, you know, think that acknowledging that that's a real thing and we need to support our providers in this industry to keep providing the good work they're providing. We also need to acknowledge that, you know, we are the front lines of doing this type of restorative justice and doing things like Lisa suggested of intentionally selecting people with previous justice involvement, or at least having not screening for it, is something that can be done, I think, you know, at the intake level to try and address this, you know, at the start. It's a great question though.
Yeah, that was a really great question. I think we have time for one more question, and the question is open to everyone. And to give you some context, in California, we have this CalAIM initiative, and I see that that's a chat into one of the questions that we have. And under the CalAIM initiative, there's FQHCs and housing providers are essentially provided an opportunity to have collaborate with different systems, in particular managed care plans, to provide enhanced care coordination, community supports for individuals experiencing homelessness and or those who have co-occurring chronic health conditions such as HIV. We have enhanced care management opportunities, and we also have community supports. What are some systems in play, or what are some initiatives that are happening in your respective regions that allow different types of systems to collaborate together to create sustainable care coordination opportunities for individuals with co-occurring conditions, including HIV? Dr. Hamilton, I see you smiling.
Okay. So we have a couple of different strategies that I'm directly involved with. First, I want to give a shout out for my colleague that I co-direct the Center for Behavioral Health Equity and Outcomes Research with. She has two SAMHSA grants for HIV prevention and substance use, targeting racial and minority populations and other populations. And so one of the things that we have done, especially focusing on youth homelessness, is she has gotten together big stakeholder groups. And what we focus on, screening, HIV prevention, testing, delivery of really brief psychosocial interventions, especially for young adults experiencing homelessness. And we coordinate with multiple FQHCs. We link to PrEP if needed, or link to HIV services. So that's one of the ways I think we are integrating care. I spoke with our local mental health authority, and they are working with Optum to also develop care coordination models, and also to increase access to long-acting injectables, because for our seriously mentally ill population, that's a really big problem. We have a lot of transportation barriers that people encounter once they are housed. And so what we find sometimes is people are going out of the hospital, and if they do end up getting housed, they really aren't making it back to the psychiatric clinics to stay on their meds. So we're looking at the use of long-acting injectables and really trying to stay with people through housing transitions. So that's something else that SAMHSA is asking us to do, is to really follow people like over the longer term, just to make sure that we are with them throughout that journey. So.
Great, thank you. And I think that about wraps up today's presentation. Thank you to our esteemed panelists for joining us this morning, and for everyone who registered to participate in this panel, in this webinar. Hope you all got a lot of really great information from this. I think some key takeaways are systems coordination, housing prioritization, and meeting the needs of clients where they are at, and looking at, to the extent feasible, ways to sort of address racial disparities and housing inequities. Because when those things go unaddressed, it can be the perfect storm for, reentries into the cycle of homelessness. And I think that that's definitely what we do not want here, and anywhere in the United States. Dr. Milburn, do you have any other final comments that you would like to share?
You summed it up really well, Mr. Sanders, so thank you. But one comment that I will leave us with is language and how we frame things. I really like that framing around people-resistant services, because it gives you a lens that really takes, I think, a different approach to understanding what's going on in the service sector. So that's, I think, another key takeaway. And I want to thank all the panelists. This was just excellent, and we really appreciate your time and all the work you're doing to address homelessness across the country.